The study showed a population health, simple, scalable intervention for chronic kidney disease among people with diabetes and/or hypertension, showed reduction in hospitalizations and readmission, and selected cost containment. So we're really excited that this short-term 2-year study with a pre and post design showed benefits in chronic kidney disease population health intervention. The study was designed to incorporate both the blood and urine testing for kidney disease, the estimated GFR and the urine albumin to creatinine ratio test. So those are tests of kidney function and kidney damage. And by defining kidney disease according to those tests and stratifying the risk at 5 different levels, we were able to employ a population health that was scaled to the severity of the disease in a patient-centered medical home with Care First, Blue Cross Blue Shield in Maryland. Why was the intervention successful? So certainly the risk stratification informing the interventions is probably the most important aspect of the study to emphasize. It wasn't just the kidney function, it was the kidney function by the estimated GFR with the urine albumin to creatinine ratio together, and a layered intervention that increased as the severity of the disease increased. The other important aspect of the study was that we did increase the use of medical nutrition therapy for the patients with chronic kidney disease, which is impactful. And then we allocated the nephrology services in a way that was more consistent with the heat map class or the severity of the disease. For example, the patients with class 5 on the heat map, which are the most severe at risk for adverse events, in the pre-intervention year, 63% of the patients saw a nephrologist. And the ones that saw a nephrologist quarterly. In the post-intervention year, 83% of the patients with CKD class 5 saw a nephrologist, and they saw a nephrologist on average monthly. So we had intensification of nephrology services for the patients with the most advanced disease, and we didn't have any increase in nephrology services for patients with lower classes or lower severity of CKD. So we allocated a finite resource, nephrology services, according to the risk stratification.